Hello everyone, this is Dr. Chandan Narang and today I will teach you about the clubfoot. Clubfoot is also known as CTEV, that's a scientific term, congenital talipes equinus varus. You have to remember the deformity as CAVE. C means cavus, A means adductus, V means varus, A means equinus. Now, cavus is because of what is the reason behind development of this deformity? Why the foot are like this, just like the club of a golf? The reason behind developing this is there are a tightness of this musculature that will lead to development of this deformity. If you look at the cavus, the cavus is because of the tightness of the intrinsic muscles of the foot and FHL and the FDL, and then adductus. Adductus is because of the adductus here I means forefoot adduction. This adduction is because of the tightness of the tibialis anterior, and varus. Varus is because of the tightness of the tibialis anterior, posterior, and Achilles, the three, and the equinus, that is because of Achilles tightness. So these are the basically the muscular forces which are responsible for the development of this clubfoot. Now, you suppose the patient is brought to you uh, by the parents, referred by the pediatrician to show this foot to the doctor, the orthopedician. So you're looking at the club foot. Now, what you have to do? Will you get an X-ray? Just the common question. Usually, 90% of the time, we don't ask for any X-ray in case of club foot. 90% of the time. If you still wants to go for any X-ray, you need to have an idea which X-ray to be ordered. Number one is a Turco view, okay. Second is the foot AP view, and in this foot AP view we need to measure the talocalcaneal angle, basically kite's angle. These are we need to measure, which is normally 20 to 40 degree, but here it is reduced because your foot, which is normally like this, now it has rotated. It has your forefoot has like it is directed medially, your heel is directed medially, so everything is rotated, spin me around the talus towards the medial aspect of the body. So this is how we remember the club foot. Now the next question is, can we like identify, when can we diagnose the club foot during the pregnancy? Is there any chance with the help of ultrasound? This definitely, the definitely with the while doing the fetal anomaly scan, you can judge that this foot might be a club foot. Okay, you can judge, but to be more sure, that will be after the pregnancy. Now, can we treat this clubfoot? Are these clubfoot treatable? Yes, they are sure treatable. And these child, when they walk, if they get treatment at the proper time, they walk normally with the normal foot appearance, with everything normal. So they are totally treatable, and without any surgery, 90% of the time without any surgery, okay, just with the Ponseti casting. Now when you see these patients, when you look at their foot are actually small. Number one. Second, the tibia is also small. Number three, normally you don't see any kind of a crease on the foot of a newborn baby. Neither you see creases, neither you see arches. These crease and arches develop when the child grows, when that neonate will enter into the other phases of his life or her life. But if you are seeing an increase in your child's foot on the medially as well as the posteriorly, it means the child is having clubfoot. That's a typical characteristic feature of the clubfoot. So now we know the examination, we know the X-ray, we know about that it is a clubfoot. Now, while assessing the clubfoot, you need to also examine that. You need to also take the history. You have to look at the patient in a way that you have to rule out the deformities, other deformities also, other anomalies also. These patients usually are the syndromic child. So you have to rule prune belly syndrome, Optis syndrome, arthrogryposis, these kind of things you have to rule out, tibia hemimelia, and there's one condition where the anteritibial artery is absent. Okay, and most of the time spinal disorders are associated with the foot deformities. If you are seeing any foot, it is deformed, don't forget to examine the spine. Okay, there most of the time you will find some findings in the spine of that patient. So let's move forward. So we know how to diagnose, we know the deformities. Now, how to treat this patient. We have two methods of treatment. One is the Ponseti and another is the French method. French method is basically a manipulation method. It's a physical therapy method where daily physiotherapy is given and with the splinting as well. But this method is not that much popular. The popular one is the Ponseti method. In Ponseti method, we go stepwise. We correct the cavus, adduction, varus, and in the end we correct the equinus with the help of casting. So there is a success rate of 90% with the Ponseti method. So the success rate with the Ponseti method is 90%. But there are few child in which even after doing all of this, there occur recurrence of the deformity. Now these becomes the child for the operative intervention. If some child is coming like at the age of 8 to 10 months of the age and there is some like recurrence of the deformity, then we go for the PMSTR and the tendon lengthenings. It means we have to release the structure which are soft tissues which are located posteromedially, and we need to do the lengthening of the Achilles, FHL, FDL, tibialis posterior, whatever the structure located on the posteromedial aspect that are responsible for like spinning the foot medially. We have to release all the structures. This is one thing we do in case of recurrent deformities. And the second is, uh, suppose the child is like coming at a late age, okay, like 3 year to like 4 years of age, and there is a recurrence of the deformity of the clubfoot. In that case, we basically do the osteotomy, okay, and at the midfoot level, and we do the cuboid decancellation procedure along with the PMSTR. And the next we have a option is the other next we have the option is of telectomy. In case of telectomy, we remove the talus where it is not easy to reduce the talus inside the mortise. In that case, we reduce the talus if the patient is coming at the age of 6 to 10. And there are other options of spatial frame, ring external fixator, they're also there, and arthrodesis options are also there. Okay, but they are the end options. Now we will discuss in details about the Ponseti method, what we actually do in case of a Ponseti method.